This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Good afternoon, everybody. A big thank you to the conference organizers for giving me the opportunity to present the results of this study here today. At this stage, I would also like to acknowledge my co-investigators, Christoph Bergmeyer, Christopher Bain, Jeff Webb, and of course, Dave Pilcher. In 2006, the first consensus conference for rapid response teams defined and described the four components of the rapid response system. We have seen this figure over and over again today. And we know that the four components are the afferent limb, or the event detection limb, the efferent limb, or the rapid response team itself, the administrative limb, as well as the quality improvement limb. As we know and as we've heard today, the rapid response system has been widely implemented across the country and is a major part of the Australian health standards now. The Alfred Hospital is a major tertiary referral centre in Melbourne and a major teaching hospital. We provide state services for multiple specialities, including trauma, burns, ECMO, VADS, heart and lung transplant. We have a mature and a well-established medical emergency team system that responds to over 6,500 med calls a year. In 2014, our MET dose was 65 per 1,000 admissions, somewhere on the higher side of the reported range seen in literature. To be clear, when I say Alfred Health, I mean the Alfred Hospital, Sandringham Hospital, and Caulfield Hospital. Majority of our MET calls are at the Alfred Hospital, the main hospital. Now, this number is only rising. The big jump that you see in 2012 is after the introduction of mandatory METs. This is where the staff have to call a MET whenever a patient meets the MET call criteria. The workload from METs is substantial, and this is despite a dedicated medical emergency team led by ICU. During the time when we have simultaneous and multiple METs, it really stretches the resources to its capacity. Our workload doesn't dwindle in the after hours when there is lack of staff around, as well as less access to specialty teams. So there is a growing demand, a demand to provide faster response, more efficient response to the deteriorating patient on the ward. But the question is this traditional model of afferent and efferent responses of the rapid response system sustainable? In addition to sustainability challenges, there are a few other challenges. The afferent response is the same, irrespective of the patient risk. So think of your young orthopedic patient with asymptomatic hypertension who's there smiling for the med team, as opposed to the elderly heart failure patient. Most of the literature in patients who have METs is focused on patients who have unfavorable outcomes. And really, there's little data on therapies administered. So is it time to think of new ways of making our MET system more efficient? So we had a hypothesis. Do the commonest MET calls result in similar treatments? And is it possible to directly institute treatment without the MET team attendance? So our aim was to identify the treatments associated with the commonest MET calls. It's a retrospective observational study. We had ethics approval. All all our Met calls, we collect data on all our Met calls. So we access this database between the periods of March 2012 and 2014. Christoph, with his colleagues, used data mining techniques to identify the most common combinations of Met call causes, outcomes, and therapies. So during the study period, we had nearly 13,000 Met calls, and this equated to 7,936 patients with Mets. Now, this is the Alfred Health Met calling criteria. I'm sure it's not very dissimilar to yours. And I'm going to put this question to the audience. What do you think is going to be the most common calling criteria? Sorry? Yep, that's what we found as well. So if you look at the number of Met calls, the most common calling criteria was hypotension. And if you look at the number of patients with Mets, again, the most common calling criteria was hypotension. Patients with Mets for hypotension were in the same age range as patients with Mets for other reasons. If you analyze the Mets as per the units, three things stand out. Gen Med had the most number of Mets, not a surprise. Hypotension was a major cause of Mets across most units, and orthopedics had a large number of patients with Mets. So patients who receive Mets due to hypotension, what are their outcomes compared to patients who receive other Mets? Well, we found not dissimilar in terms of ICU admission rate, death, and repeat Mets. We found this interesting, but probably not surprising, that Met calls for hypertension were strongly associated with immediate administration of intravenous fluid. So if a patient had a Met call, they were immediately given fluid by the Met team, unless, and this is the important bit, unless the patient was on the respiratory ward, unless the patient had a cardiac cause for admission, or were under the heart failure bed card. So just to quickly recap our findings, most common Met call was for hypertension. Majority of the patients were given fluid unless they had a cardiac or a cardiac problem or were on the respiratory ward. There were no differences in adverse outcomes. And we used data mining techniques and analyzed databases to form the above relationships. So what does this all mean? Well, there's a potential here for a systems redesign. A patient meets criteria for a Met for hypotension. Instead of calling a Met, the nurse gives the patient fluid unless the patient is on the respiratory ward or has a cardiac diagnosis. If hypotension then persists, the nurse calls a Met. Advantages, well, it preempts Mets and it empowers nursing staff to deliver the therapy quickly, avoiding a delay in administration of treatment whilst waiting for the Met call to arrive. It can also reduce the number of Met calls and the pressure that our Met team faces. The strengths of our study lie in our robust data collection, which is done by a small group of trained nurses. We use databases that were already established for operational purposes, so didn't have added costs, and we had experts analyzing our data. But there are lots of things that we need to be careful about here. In terms of limitations of our findings, this is only hypothesis-generating work and really needs to be tested in a randomized control trial. We are not saying that giving fluid is the right intervention. All we are saying is, well, you know what, this is what we've observed happening. This is what happens in the hospital. It's difficult to see how you can generalize this to all hospitals. There are limitations to the data mining technique. Your data has to be robust. There's always a risk of data dredging, problems with cost, and you need experts analyzing the data. So in conclusion, data mining techniques can identify a group of patients who, once identified as meeting a predefined criteria, could potentially have intravenous fluid instituted without the need to initiate a Met call. This could lead to earlier treatment for the patient and less total med calls. Thank you.